Mesdames et messieurs, bonjour. Vous avez l'honneur à Dr. Dangbeme Patrice. Je suis maître assistant en gynécologie.
I am a gynecologist at the Faculty of Science in Benin. I am the coordinator of the regional program for reproduction and for interventions and the prevention of SIDA. Thanks for the committee of IFCP to the honor for coordinate this session. This session will be about health and sexual and reproductive health in a context of humanitarian crisis settings. And we are with four panelists to discuss about this question. Is a very interesting question in all the French-speaking countries. This is a current situation, an ongoing situation, and I have some presentations, for example, from Cameroon, for, about the use of modern contraceptive methods within the refugees in the western, eastern regions and south regions. The second presentations will be uh, about to maintain services of ESRH during the pandemic in Guinea. Third presentation about the mobile facilities in the SRH to save lives in the south of Madagascar. And the last presentation is about services of sexual and reproductive health in a humanitarian context in Burkina Faso. It will be a session. Thanks to the panelists, you will discover this topic. Uh, we do not have the presentations of some of the panelists, but anyway, we are going to start the presentation by the second panelist, which is the presentation of Professor Yolande Marie Charlotte Hijezi, which is a gynecologist, a professor of the university in Conakry. She's dean of the Faculty of Medicine and president uh, of the Medical Commission in Guinea. I would like to welcome her to Professor Hijazi to this room. Thank you. Thank you for being here. The presentation will be a presentation, PowerPoint presentation. Are you ready to launch the PowerPoint? We 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 will give you 15 minutes for this presentation. We 15 minutes of presentation, and maybe we will make 12 minutes to allow a discussion with the audience. And first of all, I would like to
Merci beaucoup. Avant qu'on
Afterwards, I will invite Mr. Kofi Kwame from Côte d'Ivoire, representing UNFP in Madagascar, National Director for UNPA, Comores, Maurice and Seychelles. Let's applaud him. He's a baobab. He's very strong. It will be a particular session. Afterwards, we'll welcome Mr. Boubacar Sediakounouende Saba, specialist in assessment and follow-up of projects, coordinating follow-up and assessment NGO Maristop International in Burkina Faso. Susie Manuela, are you in the audience? She was supposed to be the first presenter, the first speaker. So we'll start with Professor Yolande Hijazi. Thank you, Mr. Moderator, dear colleagues, dear participants. With a huge pleasure, I will let you know about our experience in Guinea in keeping the continuation of health services in Guinea in the framework of the pandemics. The first case was registered on the 12th of March 2020. Immediately, the government decided on the implementation of the barrier measures, partial confinement and remote working. The health structures were faced with a new situation. Many cases of COVID-19, and at the same time they had to continue the providing of essential measures. Not enough resources. We had to maintain a healthy environment for the workers as well as for the people. Faced with this situation, we immediately saw the consequences. An increase or an increase in absence of workers for fear of COVID-19, a decrease of clients because they were also faced with the same threats. At the same time, the WHO decided to issue guidelines for assuring the continuation of essential services, and the government decided to support this continuation of services. And in this framework, our project could unfold. So the implementation period started in April 2020, just after the first, the official statement of the presence of COVID in Guinea, until January 2021, when the government decided to mitigate the measures to fight against COVID-19, and our study was carried out on 278 health structures in 7 out of 8 regions covered by the project. Partnership, collaboration, and coordination among different partners, technical and financial, in order to mobilize resources and design plans for providing health material, because the purpose was to secure the health services. And we also helped in buying equipment and hand sanitizers in order to provide health structures as well as communities to use hand sanitizers. Second intervention, we had to update the guidelines in order to draft a guideline for health reproduction, family planning, and infection control. And we issued guidelines in order for providers to use all the different structures in order to keep the services at every level, the health level as well as the community level. As we couldn't physically follow up, we had to organize a system in order to go on supporting the providers and making sure that the services are available. And in order to do so, we organize a regular service follow-up in order to help the providers speak about the organization of services, because one of the guidelines of the WHO would one of the recommendations was to keep the services, and we had to limit the number of providers, and the patient should find all the different services at the same place, like a one-stop shop. So we wanted to remind them what they had to do and how they had to do it, a way for them to implement the recommendation. As the purpose was to continue the services, we carried out a follow-up of the use of services by phone in order to check the trend. And if the trend was downward, we had to think of a way of attracting again the people to the health centers. So in order for the providers not to feel abandoned, we follow up the situation by phone, because we also wanted to provide people with quality service. So it was a remote mentoring involving the providers and all the different actors. We also set up a WhatsApp group for the providers and the personnel in order to speak about technical or organizational issues, as we wanted to make sure that all this activity was supporting the continuation of the service. And we checked by phone the trend of people using the center. So we cross-checked all the data in order to make sure that the trend was good and that what we could get by phone was matching reality. So in order to do so, we gave internet access and phone cards to providers in order to support the right follow-up. What are the results? We saw that the phone calls allowed us to reassure people and to go on providing services, health services, because by phone we could really support the providers, because this way providers didn't feel abandoned. And the use of a mixed approach, phone, WhatsApp group, for the psychological support and mentoring of providers was an added value for continuing health services. Here we've got a few examples of leaflets circulated where you have many drawings that was particularly designed for communities. The point was to allow people to work in a secure environment and for community people to not to fear to go to health centers. The first month after the beginning of the pandemics, people went less to health centers by 40%, and new users were down 20%. And afterwards, there was a reverse trend upwards and a continuing trend for using services and using family planning. You see the numbers circled. So in October 2021, after using all those different strategies, we saw an increase in 40% of the use of the services and plus 38% in new users on the long term. Using long-term methods, there was no trend downward. We could see a steady evolution as if there was no impact from COVID-19. So what is the takeaway of these interventions for a program that would like to make sure that there is a continued use of services? So when you organize a safe environment for the workers and the people, you allow people to go on using or providing health services. And we hadn't implemented all the strategies when we hadn't yet organized all these actions. We saw a trend downwards. The alternative actions, such as phoning or using a WhatsApp group, allowed us to support providers and continue the providing of services. And the involvement of community agents kept the trust among the people. Those results allow us to say that such approaches can be used during and outside a pandemic period in order to continue the service providing. So we can also use this experiment outside of a pandemic period, but some complex competencies cannot always be developed virtually, that is, by phone, for instance. That will not replace what we do face to face. And we have to take this into account. And this approach cannot compensate the weakness in some competencies among providers, but it allows supporting providers and making sure that there is a positive trend in service providing at community level as well as the level of health structures. And some issues with the phone and the internet can make communication difficult. Thank you, Yasa Yolanda. I think this work has been carried out by a very strong team, Mr. Umu Awapa. CK, I'm sorry if I don't pronounce your names properly. Two of them are in the room, says the speaker. Plea, Mr. Plea, Jacqueline Aribo. Congratulations for this fantastic work. And now we'll give the floor to the second speaker.
We have with us Mr. Kofi Kwame, who will present the experience about mobile facilities to offer integral services for in the sexual and reproductive health to save lives in the big south of Madagascar. This presentation, you can already see it. It was a common work that contribute to the implementation of this program. So we have the Dr. Faramala Rahelinina. Sorry for if I have this if I mistake. Who works for UNFPA in Madagascar. We also have uh, Dr. Volonina. Sorry for my pronunciation. F- who works in the on the Ministry of Health in Madagascar. It is really an integral approach between the ministry and UNFPA. And the third part of this study is Dr. Falinina Razanalizon, who is a consultant at the UNFPA. If presentation is ready, I will give the floor to our speaker. Thanks for being with us. Ladies and gentlemen, good morning. Thanks for being here. Madagascar. We are gonna present straightforward. Madagascar is the fifth island in the world with a total population of 28 million people for a country of 600,000 square kilometers. Madagascar has a population that is increasing at 30% per year. That means that each year we have 800,000 new people, which is around a city, the population of a normal city, Madagascar. Madagascar is a country of young population. Two-thirds of the population is young people. This population lives in the rural areas with I mean 80% lives in rural areas, and there's also a population who is experiencing poverty, with at least 81% of the population living with less than $1.9 per day. In addition to this, Madagascar is also living the effects of climate change. We have a drought in the south, we have cyclones in the east coast, we have floods, and if we speak about south, which is the field of this presentation, we have a 3.8 million with a small density, around 7 people for square kilometer. Sometimes it's hard to offer services, health services or public services in areas like this. We have roads, which presents also a challenge. We have also the 3 years of drought, the socioeconomic impacts of COVID-19, and all of this in place in food insecurity, malnutrition, and in Madagascar, in this south, we have more than 1 million people that have needs with, for humanitarian assistance. As you can see for the data in the field of sexual and reproductive health, uh, uh, mortality is a problem. We have around 10 women dying per day. We have also a problem during the pregnancy period. The prevalence is 40. It's 43% and not 41, as you can see on the slide. And through the last survey of 2021, we show that we have a geographical difference within the field of contraceptive. In the south, we only have a 9%, and in other regions, for example, we have at 36 and 30%. The needs of non-satisfied, the amount of non-satisfied needs in family planning, we have an average of 50% for 14.6 to be more accurate. But if we go to the south, the three regions that are in this study, we have levels that reach to 28.2%. The fertility of adolescents is very high, and as we already mentioned, due to the fact that population, uh, it's far from, the due to the density, we need sometimes more than 2 hours an average of 2 hours to get to a medical facility. So this is the reason that explains the importance of have some mobile medical facilities. We try to work in 8 districts of these three regions. We work in Boumbe, Eule, Dzombe, and Bekele. And in the Anus region, we have Ambusa, Betruk, and in the region Asimandefan, with the capital is Tulia. We have Anpani and Ichuki. And so these are the 8 places with this kind of intervention were implemented. And we are presenting for the period of 2020 to 2022. In terms of intervention, these interventions are made during the market days or during the distribution of medical products. Uh, I have to mention that we signed partnership with the UNFPA. So we need something that helps. I mean that push the population to mobilize and to come to get these services. So if this population is if mobilized for another reason, clinical services are offered on the same place. So we offer integrated services in sexual and reproductive health, family planning. We also try to treat the problems of violence against people. And in terms of methodology, we have on 3 mobile facilities. It was an offer of the Japanese government. In each team, we have an echography specialist. We have midwives, 4 midwives, and social workers. And we also offer um, dignity kits, and we are working in partnership with um, the Ministry of Health and other organizations, for example, FIDA, for the International Organization for Family Planning, and we try to mobilize also the the authorities. Thanks to this approach, we we could help around 82,000 persons. We made the prenatal consultation nine, 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 50,000 prenatal consultations and our obstetrician scan. Uh, 6,000 cases of sexual infection were treated, and some tests for HIV were also made. We also offer some urgent kits and dignity kits. That it's what it's important from which other lessons that we learn. This coordination is ensured by the Ministry of Health, and this is really important. With this coordination and the planification, we allow the teams to work on the field, and we can have access to these people, and we offer them services, including services for children, which is really important. So this partnership with governments, between governments, NGOs, and UN organizations allow us to answer to the needs of these people. This kind of initiative is also improving the access to the services, because when you go there, you have everything you can eat. You get treated. Uh, Kids are also treated. And the partnership that we sign with the PAM, it's very important to ensure the continuity of those services. And this has been done with the partnership with the Ministry of Health. But as everywhere, we also have some challenges, and we have challenges for mobilization. How can we push the people who is living on the mountains to come to see us? Anyway, the idea of clinical mobile facilities is very important, because we can offer a door-to-door services to this population. This is what has been done in partnership with the direction of our Ministry Health Ministry. With its here we have also we have our minister with us, Ladies and gentlemen, that's what I wanted to tell you regarding the experience we had in Madagascar, and we are ready to answer to all your questions. Thank you.
Minutes par rapport.
So, thank you for sticking to the time. We welcome the presence of His Excellency, the Health Minister of Madagascar, in a country where, as any other minister, wants to develop the sector to accompany the NGOs. I don't think everybody has seen the minister. I don't know how we can manage to show him. I haven't seen myself the minister. And I think when I stand, I have a better opportunity to see his face. Let's applaud the presence of the Health Minister of Madagascar. Thank you for your presence, Mr. Minister. And at the end, we'll give the floor to the Minister in order to see what's worked in this partnership, to register all the achievements. And last speaker of this session, as dear Susie is not present, so we'll listen to a representative from Burkina Faso. Maristop International, a representative of Maristop International will take the floor. He will let us know about the service providing in sexual and reproductive health in a humanitarian context in Burkina Faso. Coordinator, follow-up and assessment of Maristop International based in Burkina Faso. The NGO was set up in 1976 and is present in 38 countries. The purpose is to fight for protecting sexual and reproductive rights and to fight against STDs and other transmittable diseases. Mr. Mateo, in charge of innovation research. Mr. Dana Wangwa. The floor is yours for 12 minutes. Thank you. Ladies and gentlemen, good morning. I have the honor to present to you this morning the experience of Maristop Burkina Faso NGO providing HR services in Burkina Faso. First point, we will show you the context, what are the challenges. Then we will let you know about the intervention, multi-level intervention itself. Then we will use the routine data collected during the intervention, focusing on internally displaced people, key results and takeaway. So what is the challenge we've tried to face? We are in French-speaking Western Africa, and since 2015 the country is faced with terrorists the same way as in Mali and Niger. The situation has worsened, and as a consequence, some health centers have been closed, and 4.9 million people are faced with health issues when they have to go to health centers, and give or take 1.5 million people have been displaced and have issues accessing general health centers. These people are very vulnerable, and it deepens the issues at providing the different regions, worsens the situation. So in green, we can see the regions that are faced with insecurity, and where we have ad hoc centers for supporting displaced people. And this action is supported by what we call married stop ladies. We started in 2019 in the Kaya Health District through two married stop ladies, MS ladies. They travel around with motorcycles in an area of 50 kilometers, providing services in SRHR. Two other regions in the north and in the east were supported also later. We have a partnership with social action municipalities and focal points in order to provide SR and FP in the health centers. We organize focal points for providing health services. We try and raise awareness in order to make sure that all the displaced people have access to information, and we can set up small tents in order for displaced people to have access to such services. We interviewed a Marisop lady, and she told us that every morning she wants women, and particularly young women, don't have to face unwanted pregnancy. So this is her motivation to go to such areas despite the lack of security. And we also wanted to use the routine data collected in order to understand the situation of internally displaced people. Very soon, we started using the routine data as soon as 2019, and in 2022, we improved the collecting system. We are integrated in the client.kaya collect site. It makes data manipulation easier, or data management. The data come from 3 regions, in particular from Uahiguya, Kaya, and Fada. 8,848 visits of registered clients between January and October 2022. In order to understand the nature of SRFP services provided and the profile of clients who received such services. Key results. Once we checked the data, we could produce some key results. We started our action in 2019, and when we started with 2 married stop ladies, and in 2020 we added a mobile team supporting 2 other health districts, and in 2021 we added 2 more married stop ladies, but due to the pandemics we had to limit our action to 2 married stop ladies, and in 2022 we added 2,800 involving people, offering our service to people under the age of 20 in particular. So what is the profile of the clients we can reach? They're quite young, a slightly higher number of teenagers, 29% of new users, and 86% of people not using any family planning solution. What type of family planning services our clients use on site? Very often they prefer long-lasting methods. So the majority of the methods they use are long-term methods. Due to precarity, they prefer to use a long-lasting method. They are also interested in discretion, and they prefer long-lasting methods instead of using self-injecting methods. So what are the takeaways? We can say that internally displaced people prefer community sites, public health centers, for discretion issues. We also have to raise awareness through the peers in order to have the SRHR services better accepted. We also have to adapt the offer to internally displaced people for their particular situation. We're also to protect better the displaced people, offering a range of services and not just one service, like a one-stop shop. And in 2022, we have intensified the awareness-raising activity through peers. We identified leaders in order to go on providing the right level of information. We improved the partnership with different agents in order to make sure we provide services complementing each other and a better coverage. We also have to improve the quality of our offer and to organize the services through packages in order to give a better answer to the particular situation of internally displaced people. Now I've reached the end of my presentation. Thank you for listening. I will welcome any comment or question.
La présentation. À présent, je vous prie de rejoindre votre
I ask you to take a seat. I ask if Mrs. Susie Emanuela Obama is here and if she has her presentation or not. Is she here or not? No. Okay, so we are closing this session, and we are now opening the Q&A session. In case if you have any question, any contribution, I'm gonna try to resume the third presentations. First of all, humanitarian crisis is only a crisis when we have when we have infectious causes like COVID-19 or others. We also have a food crisis, and that is what have been shown. Guinea have shown us what we can do to improve all the problems, the offer of services, continuity, and others. And finally, if we take, for example, Burkina Faso, thanks to the work to this international NGO, we talk about humanitarian crisis related to insecurity when we have refugees, when we have a crisis. It's every single stage of society that is being affected, and that we understand thanks to these three presentation is that in case of humanitarian crisis, we need what we call a partnership. Partnership should be interesting for NGOs, government, and the community. The lack of implication from one of the three actors, it's uh, it's a failure. We need a partnership between these three actors to have to success. What I can understand, thanks to the presentation of Guinea, COVID-19 made that we have um, some mm, some reticences and reluctance from the health personnel, and we we have a problem of frequentation, and the objective is to improve this frequentation. And thanks to the presentation of Madagascar, we understood that the that alimentation that food um, it's it's something that has been used as an attraction to offer medical services. We need to know that hunger do not make distinction with health or unhealth, but first of all, to offer health, we need to feed the people, and the government and other partners have to understand and should take Madagascar as an example. If because if people are hungry at the school, I mean on the daily life, they won't take care of the health. And the presentation of Burkina Faso, it's aligned with the presentation of Madagascar with regarding the approach for refugees. It is almost the same idea. I give you the floor if you have any question or you have any comment. Thank you. We can. Okay, don't. So if we are gonna take a few questions at the left, is there any person? Yeah, you can take the floor. Yes, yes, you have the floor. Can you present yourself? People want you to know, wants to know you. I am from the Togolese Association for Wealth. Thanks to the the panelists. Unfortunately, uh, I only followed the presentation of Madagascar and Burkina Faso. Thanks for your efforts. I have two or three questions. First of all, to Madagascar. You have 2 minutes. You have 2 minutes, sir. Okay. In his presentation, talk about the population in rural areas. We have to make everything to them to come. So, which is the strategy to offer them these services? And in the case of Burkina Faso, in the presentation, I understood that the PDI prefer conventional facilities. So, which is the role of MSL 10? And the other aspect is now within the context of security. I think that terrorists take take care of health services. Last time I was in Kogodugu regarding some NGOs that have to do erase the name from the vehicles to circulate in the country. So which are the E elements to protect these NGOs? Do we have other interventions here? Yes, in the right. Thanks. I have some question to the second panelist of the UNFPA. He shared the experience about the mobile facilities. That it's something that has been made in Guinea in the frame of our intervention. I would like to you talk about the partnership with the ministry, but more specifically, uh, the health department is concerned is implied or not. For example, when we have the this kind of
Présentation du Burkina.
Regarding the presentation from Burkina, you've spoken about Excel trackers, and I would like to know the level of collected data, what is confidentiality given the clients you deal with, and what is the integration of the national health system in order to make the best possible use of those data. Does anyone else want to take the floor? Sige Player from the Guinea Pact. I would like to provoke you, particularly the second speaker, the fact that you associated food with family planning services. Did you were you cautious in order for people not to associate the fact that you give food and at the same time you give a pill? So people looking for food, what was the level of counseling in order to make sure that people really choose to take the pill and not accepted to take the pill in exchange for food? My name is Juliette Nathalie from Burkina Faso, Well-Being of Women Initiative. I've got a cross-cutting question. I think it's for all the speakers. I'd like to go back to the issue of quality, because in times of crisis, we want to provide care. This is our purpose, our first purpose. How can you keep quality in the service we provide? Let's take, for instance, the issue of Madagascar. We've got mobile hospitals and we go to people. So how these women, these young girls, do they feel at ease when they're being provided with services? Is it adaptable? I think it's the same issue in Burkina Faso, but I can see that Maristop on site sets up tents in order to speak with young women. But how can you keep quality, confidentiality when dealing with women and young women? Maybe it's trivial, but a security crisis is an opportunity, because all the experiences you've spoken about our situation, we can keep beyond the crisis, because this is something we have gone through. And so this is one of the takeaways. Thank you. If you don't have other questions or comments, I'll give the floor to the first speaker, Professor Yolande, because the cross-cutting questions interest everybody. So she will reflect on the Guinean experience. So in times of humanitarian crisis, how can we keep quality, and what is the quality of the intervention? Thank you. As a matter of fact, can you hear me? This is one of our worries. I'll take the specific example of COVID-19. The fact that we couldn't have a face-to-face supervision and we couldn't support physically the providers in order to make sure that the right services were offered according to the standards in order to provide people with quality services. We organized remote mentoring, because we want people to use the services even during times of crisis. That's why we organized remote mentoring in order to make sure that the services provided are as good as the type of services we want to provide in normal time. And it reassures the providers. The providers don't feel alone. The provider, they know that they're being supported, helped. So never lose of sight the idea of quality, and all these acquis, all these takeaways have kept on beyond the pandemics. For instance, the WhatsApp group allows peers to speak about different situations and possible solutions. So this steady phone follow-up has allowed us to keep the takeaways. And when you mentioned the mobile hospitals, family planning involves a lot of people, but we always make sure that there is one place where we can have confidentiality, and we provide the right counseling activity in order to make sure that people go on using family planning methods. Thank you. Now I'll give the floor to the representative of Madagascar. If your mic doesn't work, you can use mine. Thank you. Thank you for your interest in our presentations. We can feel that you're interested in these issues. So for the first question, for people living in the mountains, I think awareness raising is paramount in order for people to get out of the mountains and search services, because some services cannot be provided within the community, within the mountains. It's not possible, technically speaking. So what we try and do in the team, we have social workers whose action is to raise awareness in the communities. And we also organize groups taking into account that these communities are patriarchal, that is to say that the power is in the hands of men. We not only have to convince women, but also we have to convince men to let women get out of the community in order to access health services. So when we set up a hospital just outside the mountains, we have to make sure that people get out of the mountains in order to go to the health center. And contraceptive methods cannot be given away like sweets. These are pills. These are medicine. So we have to take account also the infection situations. When we speak about health, we cannot have an advanced strategy without involving all the health centers, because some issues will have to be sent to a specific health center. And this is the way we can send difficult cases to specific health centers. When I visited a health center with the First Lady, a woman who was having her fourth pregnancy had reached 9.5 months of pregnancy. It was an emergency situation, and this when we decided to send that person to a health center with higher technical equipment and possibilities. And this is the interaction between a mobile hospital and a fixed health center. I don't see here when you speak about food and pills, family planning is given on a voluntary basis. I think you have to take as an approach the idea of access to service, and the awareness raising works on access to service. So social workers send this message. A lot of people are involved. So through this awareness raising action, we give the information about the possibility of accessing a series of services in such an environment. And if someone is faced with a specific need, a specific problem, and needs contraceptive methods, that person will go to the mobile hospital. And don't forget that we're speaking about tents. We could see that on pictures, and part of them, clients or people interested in receiving such services, have to go around the tent to enter it. And this is a way for giving women discreet access to the hospital, because the services are not provided in the car, because you have to go into the tent in order to receive the services. And this organization allows or guarantees a certain level of quality in the provided services. And it addresses also the issue of confidentiality, because the access is not direct. But on the other hand, we cannot stop people from watching who enters the tent. But this is when women have to choose whether to use the service or not to use the service. It's, as I said, on a voluntary basis. Now, when the people have understood the general awareness raising action, then you have a face-to-face interaction between the provider and the client. And this is when the client decides whether they want to use an intrauterine device or an implant. I've got a question. In case of a humanitarian crisis or catastrophe, do you still stick to the standards that have been developed through your experience? There's always margin for maneuver, but services cannot be provided if they don't respect confidentiality, norms, etc. So it's part of the doctor's job, it's part of the health personnel's job. So we try and respect the norms as much as possible. I wanted to ask this question. There was a way of taking advantage to the question about associating food and pills. I just wanted to make sure that we don't act before thinking. So in a normal situation, providing services is different than providing services in the framework of a humanitarian crisis. So as professional workers are involved in providing services, we can be reassured that the quality of care and quality of services are kept. Now I'll give the floor to the representative of Burkina Faso. If I'm not wrong, there were two questions. The first one, the takeaway, community sites are preferred to traditional or conventional health sites for confidentiality issues. The centers are closer to their areas or to the areas where those people live. Speaking about security, given the situation in Burkina Faso, the NGOs and the security department, we use motorcycles every morning before taking their motorcycles. They have to give a call and to let the contact person know about their location, and actually during the day the location has to be informed. Branding. In a security area there is no branding. The workers dress up as standard people, normal people, like any woman would dress up. They can even take public transport. They've been trained on security issues, how to behave. And if you have a look at the figures, you could see that in 2022, we reduced the number of workers. So the answer is not always obvious, but we never force people to enter, to go out of their comfort zone. But things will improve in order to stop this trend. But we go on working in a difficult situation. Now, regarding the data integration, when Marisop workers intervene, the center is in. The ministry has strict rules. We work with social action, municipalities, and sanitary or health, the different health structures. The way we manage data is the same as other structures. The quality, as we said, as an example, when we work with focal points, we train them in order to relay the information at a certain level. When the client gets to the provider, she knows the different possibilities, and then she's given more information in order to make an informed choice. So we always think of quality. We also have a quality assessment service in order to remind the providers the importance of providing a quality service. I think this is part of my answer. I want to thank all the speakers for the quality of the answers they have given to the different questions. I think the people who asked the questions are happy with the answers, and we will conclude saying that humanitarian crises are of different natures: food, environmental, infectious, etc. And such crises allow us to be innovative and taking into interacting with the communities, the government, and different involved interested structures. So the takeaway for this session would be that in situation of humanitarian crisis, the partnership involving 3 partners should be kept. Secondly, the effort for keeping safety and security in providing services, whether it is an advanced strategy or anything else, should be kept on board. We have to make an effort to keep quality on board. And third takeaway, organize everything as a routine when we learn a lesson through a humanitarian crisis. This is the end of this session. Thank you for attending it. And last but not least, I want to remind you that 278 training sessions supported by US aid. I'm sorry, I made a mistake.